Okay, good morning, good afternoon, good evening po sa lahat. Saan man pong panig kayo naroon sa mundo. Welcome po to our 182nd episode of the Stop COVID Deaths webinar series, now called Health Updates po. Thank you for being part of our credible online community. And to all those who have just discovered us for today, welcome po. At sana po marami po kayong matutunan sa ating, well, very interesting. Hindi lang po siya masyado na pag-uusapan po na topic for today's webinar. It's about Buwa or pelvic organ prolapse. So it stands as a prevalent yet often overlooked condition affecting countless women po sa buong mundo, pati na rin po dito sa Pilipinas. And in our webinar today, we'll do a deep dive into it, trying to find the foundation po na solid for understanding the dynamics that lead to POP or Buwa. Pag-uusapan po ano po ba yung kailan po ito nangyayari. So oftentimes pag naririnig po natin to kung mayroong childbirth trauma or merong mga hormonal changes, may mga to genetic predispositions, yun po yung mga pwede pong that may put individuals at risk for this one. At ano po yung pwedeng maging progression ng ganitong kondisyon? Ano po yung mga diagnostic modalities para matuntun po ito? At ano po yung mga pwedeng maibigay na, let's say, interventions po para po matugunan yung problema ng ating mga kababaihan. Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institute of Health, University of Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And for today's webinar also, again, I have with me our PGH Coordinator for Training, Dr. Dion Sakdalan.
Hello, good afternoon, Dr. Raymond, and welcome to everyone. Welcome to all those participants here in the live broadcast of Zoom, and to all those watching via live streaming on the TVUP YouTube channel, and also those watching through UP System Facebook page, the TVUP Facebook page, and of course, all those watching from TVUP Signal TV channel 101. Welcome also. We are very privileged to have two of the most sought after urogynecologists in the country. Welcome to the webinar, Dr. Rani Cadiz and Dr. Lizette Prodigalidad-Habson. Also, finally, we also welcome back again all our attendees. Our shout out to our loyal viewers from Rizal, from Bulacan, Bataan. Meron pa pong sa Algeria, sa Saudi Arabia, from the University of Rizal System, RHU, and the UST ENT HNS Center. Again, welcome po to everyone. So, as mentioned by Dr. Raymond, we've changed our title. We now call this program Health Updates, and we've done a little reformatting of our program, but we are maintaining the same high-quality presentations and discussion of existing and emerging health problems in the Philippines and the rest of the world. So for this year po, we want to go immediately into the heart of the discussion, and so our program is a bit shorter. But before we go to that presentation, Dr. Raymond, you want to introduce our person on the street video?
Okay, thank you, Dr. Dion. You also probably you got a glimpse of our main speaker po mamaya. Mamaya po papakilala po natin siya. For today's person on the street video po, which is something that we're very, very thankful to the TVUP team for coming in, week out po nito, trying to understand ano po yung baseline po na understanding nila about the topic at hand. And for this week's set of interviewees, ang mga tinanong po namin sa kanila, alam niyo po ba kung ano ang buwa? May kakilala po ba kayong nagkaroon ng buwa? Ano po ba ito sa tingin ninyo? Ano-ano ang mga narinig na ninyong dapat ginagawa kapag may buwa? Please watch this.
Actually, ang buwa is prolapse uterus. Parang lumuwa yung uterus mo.
I know pelvic organ prolapse. That's when, parang when your uterus for females, no, it goes out of the body. Pero hindi ko pa narinig yung term na buwa.
Yes, I know what buwa is. Yun yung nalalaglag yung uterus sa vagina.
Wala pa naman akong nakilalang may buwa. Pero narinig ko na about yung mga ganyan na cases.
When I was young, parang meron akong isang auntie na I heard nga na yun, she had several kids, and then they said that's what caused like her uterus or yung mattress niya na come out. But I wasn't too sure ano yung specifics of this condition and how exactly it was treated.
Sa ngayon po ay wala pa po.
Usually, yung mga nagkakaroon nata ng ganyan is mga sunod-sunod yung mga anak and nagtatrabaho sila ng mabigat. So, yun yung nag-focus ng pagluwa ng uterus nila.
I think parang wear and tear type of disease siya. It's probably not like infectious, pero yun nga, wear and tear of the body as of a woman's body as it does its thing throughout life.
Yun yung nalalaglag yung uterus o yung mattress ng isang babae, lumuluwa siya nakikita siya sa may vagina. Kasi nangihina na yung mga kumakapit sa kanya sa loob ng kanyang katawan.
May mga exercises na ginagawa daw. And then, kung talagang malaki na siya, probable thing that you have to do is to have surgery.
Sa pagkakaalam ko, pwede kang magpa-surgery para ayusin yung mga lumuluwag o nasisirang mga bahagi ng katawan sa loob mo. Na ang rason kung ba't siya nalalaglag. O pwede din lagyan ng pampakapit yung mattress mo. Tawag ata nila doon ay pessary.
Actually, parang mag-exercise. If that's what I saw lang on social media na can do like Kegels or baka in general lang kailangan eat well, ganun. But yeah, probably mag-exercise.
Well, thank you so much, TVUP. Lahat po na narinig po natin, no? It's all about really, I think there's a baseline understanding naman po kung ano po yung buwa. And their understanding also is yung exercises and surgery. But we'll hear more from our speakers po and our experts about the topic at hand. But before we start lang po, we want to mention that all of our certificates of attendance have already been sent out for all 181 webinars. Those who have received them were the ones who watch at least 50% of the webinar duration. If you have any questions, and that's something that we have been trying to improve upon, our feedback po, no? And trying to answer each and every individual email na pinapadala po sa amin, please continue to send those at stopcovideds@up.edu.ph. For our webinar today, we'll be having a standard panel discussion format. And after our speakers have presented, that will be followed by a Q&A session. So I'll turn the floor over to Dr. Dion for our main presenter for today.
Okay, thank you, Dr. Raymond. So we go straight to the presentation. And this speaker of ours is an alumni of the UP College of Medicine and the training program of OB-GYN and Urogynecology. She's now an active consultant in the Division of Urogynecology and Pelvic Reconstructive Surgery of the Department of Obstetrics and Gynecology of the UP Philippine General Hospital. She's also the head of the Urogynecology section of Batangas Medical Center. Please welcome our main speaker, Dr. Mary Rani Cadiz. Good afternoon.
Hello. Good afternoon, everyone. So we have a very interesting topic this afternoon. I'll be sharing my screen
Go ahead,
to start our lecture.
Thank you.
So I hope you're seeing my screen. Okay.
If you could just go to slideshow, ma'am.
This is better.
Yes, po. Go ahead.
Okay. Okay, as I mentioned, we have the topic Buwa, pelvic organ prolapse, as a silent treatment. I'm sure many of you, well, as we've heard a while back, are already familiar with the term, or at least have a working idea. But somehow this topic is also covertly discussed. So even though it's familiar to many, it may not be readily discussed, as there's some form of embarrassment associated with pelvic organ prolapse. So what is it really? So POP, or pelvic organ prolapse, otherwise known as Buwa. But what is Buwa? We've heard from our interviewees that it's actually, their concept is about uterine prolapse, or the mattress going out of the vagina. But actually, it's the descent of any of the following. So it could be the bowels, the bladder, urethra, or uterus. And note that even those who had hysterectomy before may still have, because sometimes they find it interesting or somewhat unusual that they've had hysterectomy already, and yet they have Buwa. That's because there's weakening of the muscles, ligaments, and tissues that support the pelvic organs. And as mentioned, these pelvic organs may be any of the following. So when there's weakened pelvic floor muscles, one or more of these organs shift out of their normal position. So organs such as the vagina, uterus, bladder, and rectum tend to sag or bulge. So it's not just the uterus per se. So we have here a picture. So we have a urethrocoele, cystocoele, and the uterine prolapse. But in general, it's called pelvic organ prolapse. Why do we need to talk about it? So at the global level, there were 13 million incident cases of pelvic organ prolapse in 2019, with an age standardized incidence rate of 316.19 per 100,000 population. And these data were extracted from the Global Burden of Disease 2019 database for 195 countries and territories between 1990 to 2019. The prevalence ranges from 41 to 56% for clinical evaluation, meaning this is an objective measure. But not all patients with objective pelvic organ prolapse finding would present with symptoms. It may range from, the symptoms may be present in 3% to 7% of the population. Worldwide, about 40% of women will experience pelvic organ prolapse. And this proportion is expected to increase with the aging of the population. So it's really not that disturbing, but it's something that we should be aware of. The aging process, as we know, is the most frequently reported risk factor for pelvic organ prolapse, followed by parity and obesity. Based on a study by McKean and colleagues on the review of etiology, presentation, diagnosis, and management of pelvic organ prolapse in 2011. As for the age distribution, the ratio of female incidence among different ages showed a bimodal distribution. So it peaks in the 50 to 54 years of age, and then again at 65 to 69 years age group. It is reported that the proportion of women aged 70 to 79 years old seeking medical consultation due to symptomatic pelvic organ prolapse is the highest, and it is as high as 18.6 out of 1,000 women. So that's a lot. In our country, we don't have the exact data, but to give you a picture, I see such cases on the daily in varying severity. So does pelvic organ prolapse matter, or at least talking about it? Is it relevant? Well, a woman's lifetime risk of surgery for pelvic organ prolapse could be 12 to 19%. In the US, since we don't have much data, POP accounts for 15 to 18% of hysterectomies, and uterovaginal prolapse is the most common indication for hysterectomy in postmenopausal women. Now, the numbers may be underreported in our country because we don't have an extensive data about it. But despite these, seemingly the topic is not well discussed, like hypertension or myoma or even infertility. So what are the usual symptoms or presentation of pelvic organ prolapse? I'm sure some of the patients will not share it readily. They will not tell na, Doc, I have vaginal bulge o meron akong nakakapa sa puwerta. So the usual symptoms are the following. We have pelvic heaviness, low back pain, feeling that something will come out of their vagina or parang mamanganganak ulit. Urinary symptoms would include urinary frequency, feeling of incomplete voiding, straining to urinate, vaginal bulge, which is very common, unprolonged standing or straining, and constipation. These are just some examples of the symptoms or presentation of pelvic organ prolapse, but it could have many manifestations. So we catch the suspicion of having pelvic organ prolapse by asking our patients directly, because oftentimes they will not volunteer these information. So just a review, we have the support of the pelvic floor. One is the interviewees mentioned about weakening of the muscles or wear and tear. So I think she's an occupational therapist, so she's quite familiar. Now, the main support of the pelvic floor is the cardinal ligament and uterosacral ligament, as you can see here in the picture. Now, through time, it may weaken together with aging. So we have different levels of support, the vagina as well as the uterus. When we say level 1, we're talking about the uterosacral ligament and cardinal ligaments. The level 2 support, on the other hand, is the support of the mid-vagina, provided by the connective tissue attachments to the arcuus, tendinous, fascia pelvis on the lateral pelvic side walls. Level 3 support of the distal or inferior vagina is provided for by the perineal membrane and muscles. And all of these attachments are connected through the endopelvic fascia or connective tissue. So this is just being technical about it. To give you an idea with how the different types of prolapse may appear like, we have here a video also grabbed from YouTube. So as I've said, pelvic organ prolapse is the general term. So when we say prolapse, it could be a cystocele. So it's not just the uterus per se. So with cystocele, it is the bladder that is descending or coming out of the introitus. Sometimes it could be an enterocele. And when we say enterocele, it could be the bowels going down. So at least here you have an idea, more or less how it looks like. And then rectocele, it is the rectum that protrudes into the posterior vagina. But oftentimes they are in combination. So uterine prolapse, this is what most of our patients are very much familiar with. So when they feel a bulge, they automatically assume that it may be because of the uterus prolapsing out. We also have vaginal vault prolapse, meaning to say even those who've had hysterectomies may have the bowels, the bladder, and even the rectum prolapsing or coming out of the vagina. One of the questions in the chat box include common risk factors for pelvic organ prolapse. So what are those? We know that menopause or aging is one. We have pregnancy and childbirth. I think many of our interviewees also mentioned those. But obesity is one risk factor, especially if there's increase in abdominal girth. Lifestyle or the nature of work, any increase in intra-abdominal pressure could be because of a mass, or constipation, chronic straining. We also have nerve injury, genetics, so nasa lahi somehow, and even smoking. But the pathophysiology of POP or pelvic organ prolapse is multifactorial. You can't just pinpoint one risk factor and that would be the end all and be all. So we have a model here presented by Bump and Norton to propose a mechanism for the development and progression of pelvic floor dysfunction, and this includes pelvic organ prolapse. Actually, being a female in itself is a risk factor because only women have pelvic organ prolapse. But inciting factors, which is commonly known to us like childbirth, radiation or radical surgery, could also be a risk factor. We have promoting factors like constipation, chronic cough, obesity, and even decompensating factors such as aging, dementia, or medications. There are ways to intervene or at least address this concern, which we will be discussing later on. So why is pelvic organ prolapse a silent burden? Is it really silent? I mean, it's not discussed as often. We have established that already. But women with pelvic organ prolapse may experience not only symptoms such as vaginal bulge, pressure, or even urinary or bowel dysfunction. But there are functional challenges related to sexual function, body image, continence, and even pain. There's a strong attachment of emotion, including depression, anxiety, and sadness, as described by some patients. Actually, I often hear in the clinics, Doktora, mahirap maging babae. And that's just because they have pelvic organ prolapse. So meaning to say, it's not just because there's a bulge. They feel an emotional connection with their condition. Feelings of anxiety are often associated with a feeling of uncertainty, of something being wrong. They somehow feel that they're not the same as with their peers or contemporaries. Because even though they have a neighbor who delivered, let's say, 11 babies, they may not present necessarily with pelvic organ prolapse. So they blame themselves or ask, bakit ako? Or kung kailan pa tumanda. So those are the things that I hear in the clinic. Now, several subjects also describe concern and anxiety for the fear of having cancer, because usually we stage pelvic organ prolapse. And when they hear the stage, they think it is a malignancy. So others describe anxiety about the change in their day-to-day routine because of the condition. Sometimes the relatives or the children do not understand much when they learn that their parents or their mother have pelvic organ prolapse. They feel that, oh, okay, there's just a bulge coming out. But actually, there are other associated changes, including the way they walk, the way they do their daily activities. And some women find it difficult or find that there's shame in discussing their symptoms with their loved ones or even with their doctors. So there's much secrecy or embarrassment with pelvic floor disorders, even amongst other women. I mean, when they hear that one of their friends or relatives have pelvic organ prolapse, they have some connotation as to why it happened. So that's the thing that I think we have to change. Although we know that many women would have pelvic organ prolapse for decades or for several years, there may be problems associated with it. So there may be ulceration, bleeding, recurrent urinary tract infection, vaginal discharge or infection, incontinence or urinary problems, sometimes low back pain, urinary retention, and bladder outlet obstruction. So just to give you an idea, here are some pictures. Many patients would have pelvic organ prolapse as big as, let's say, a fist of a baby or even bigger. But they don't necessarily consult because they feel that it's just the norm. However, they do go to their doctors if they feel there's an infection or if there is bleeding. So these are just some pictures to show. And in cases wherein the prolapse no longer goes back inside the vagina, there may be incarceration or associated pain. So what is the stage in pelvic organ prolapse? What are those stages? So it's not malignancy, definitely. And the pelvic organ prolapse stage would only denote how advanced the prolapse is. So as mentioned, it is not cancer. It's just a measure of how far or how near it is to the introitus or the hymen. There are different ways to approach pelvic organ prolapse. So we have 3 options actually. One is observation. We do nothing, we just advise. Next is conservative management. It would involve Kegels exercise, pessary. And the third would be surgical. For the patients complaining of urinary and bowel symptoms or those with daily palpable bulge, observation is not an option, definitely. We need to do something about it. But in cases that the patient is not desirous of any surgery, conservative management may be advised. Or if the prolapse is still stage 2, it's not that advanced, we may do Kegels exercises. Well, currently, there is no fixed protocol for Kegel exercises. But the fundamental rules include to identify the appropriate muscles which stop or slow the urination. So these are the pelvic floor muscles. And these muscles would have to be contracted. So either fast or slow. It's a real workout, actually. It's like going to the gym, except that you can do it at home while standing, while being seated, or while lying on the bed. Now, these exercises would have to be repeated for several times, not just for a week, not just for 2 weeks, sometimes for 8 weeks or more, 8 to 12 weeks, and more is encouraged. And then when these exercises are repeated, there are attempts to prolong the contraction or holding time of the pelvic floor muscles. It's really like exercising or building up the muscles. Now, for patients with advanced pelvic organ prolapse, of course, not much change in the anatomic position will be expected, even with religious doing Kegels exercises. We may offer pessary. So when we talk about pessary, it is a soft, removable device that goes inside the vagina to support the areas that are affected by the pelvic organ prolapse. In the vernacular, I liken it to calso, or sometimes the patients say it's like a stopper. The material may be made of PVC. It could be made of medical grade silicone or sometimes rubber or plastic. So it really depends. But as you can see here, there are different types of pessaries, different designs, different sizes. So it's not a one size fits all kind of thing. It would really have to be fitted per patient. And this is how a pessary may look like when inside the vagina. It may be offered for patients who are not good candidates for operation or those who don't want an operation at the moment. They may opt to have pessary for the time being and later on decide to have an operation. So it can be used for a while, for a long time, although depending on the type or design of pessaries, one would need to clean the pessary regularly. It could be in the clinic or done by the patient. So it's not something permanent. I think that's what we need to emphasize. Because some would think that once you place a pessary, that's it. You won't do anything about it. Nakapasok na. But there's still pessary care. The patient would need to go to the doctor regularly for checkup. How about surgical management? Well, it may not always mean abdominal approach. So that's one thing we need to clarify. Because when people hear about operation, they automatically assume opening up the abdomen or doing outright hysterectomy. Well, it would really depend on the compartment affected and the stage of the prolapse. The patient's risk factors and decision would also be incorporated in the planning. Now, these are just examples of the different operative approach for pelvic organ prolapse. So these are, as I said, samples, not absolute. So if the prolapse is already advanced, we can do vaginal hysterectomy, macholcodoplasty as apical support, the anterior and posterior colporrhaphy with or without iliococcygeal fixation or sacrospinal ligament fixation. If abdominal route is indicated or has been decided, one can do total abdominal hysterectomy with or without bilateral salpingo-oophorectomy, and then an apical support, an example of which is uterosacral ligament fixation. So these are examples. Note, however, that vaginal hysterectomy alone does not address the prolapse. So I think that's one misconception. In fact, when the major support of the vagina and the uterus are cut from hysterectomy, we have reviewed a while back, we have the uterosacral ligament and the cardinal ligaments. And during hysterectomy, those are severed. So when those are cut, we lose the Delancey level 1 support or the apical support. That is why we try to reconstruct the apical support, because it is the cornerstone of many prolapse surgeries. So we will not be specific about the steps, but I just want you to be familiar that there is anterior colporrhaphy for those who have anterior vaginal wall descent or cystocele, urethocele. We may proceed with anterior colporrhaphy, and the principal aim of any surgical repair of the anterior vaginal compartment includes restoration of adequate vaginal length, caliber, and support. So we do not want to cut as much vaginal epithelium as possible and make the vagina as short as this. So we want it to be as close as possible to the normal length or position. A posterior colporrhaphy or repair is a surgical procedure if there is posterior wall descent, let's say rectocele or enterocele. And this procedure aims to repair or reinforce the fascial support layer between the rectum and the vagina. Because sometimes it becomes thinned out, especially if the patient had several vaginal deliveries. Sometimes we also do perineorrhaphy, wherein the perineal body is repaired. However, please note that this is very different from pampasikip because many patients go to the clinic and tell us, Doktora, pwede po magpasikip. And I would want to understand the context why they would want to have pampasikip procedure. But we are talking about reconstruction. We try to bring the organs back in their normal place. Referral to your gynecology is suggested if our colleagues would like to ask for help or would need assistance in apical suspension, because we could offer the following. We have ileococcygeal fixation, uterosacral ligament suspension, and in cases of enterocele repair, we could do also macolcodoplasty, cul-de-sac closure, and the likes. For difficult surgeries, or if there's a concomitant need to address the patient's stress urinary incontinence, referral may also be warranted. Suppose we're done with our operation, and these are the things that we have to do afterwards. We need to maintain the Foley catheter for 48 to 72 hours. Why? Because the bladder would need to rest, as well as the urethra, because after the operation, there might be a bit of edema or swelling. So there should be enough time for the edema to subside so that there will be no feeling of blockage or parang may natitira. So adequate urine drainage should be done, and the patient may actually ambulate with care around 8 hours or even more after the operation. While the catheter is in place, excessive manipulation and traction of the catheter should be avoided. It's very straightforward. The patients generally tell us that the pain is more manageable post-op. So the bleeding or the blood loss is not that much usually, but this comes with careful planning. What are the possible things that we have to watch out for post-op? So we need, as I mentioned a while back, we need to monitor the urine output. And if there is poor urine output, we have to be alerted immediately. The possible causes of poor urine output would include kinking of the catheter. So first, we do not panic. Probably it's just because the catheter is blocked, or there may be blood clots blocking the Foley drainage. It could be that the patient is dehydrated or would need more fluids. In the worst case scenario, because of the proximity, we have the possibility of ureteral injury or bladder injury. The surgical management is considered a major operation, just like our abdominal hysterectomy. Therefore, the things we prepare and watch out for in any major operation would have to be considered. We do request for cardiopulmonary clearance, and we have to explain the risk and benefits of doing operation for prolapse. We cannot just tell, you will have the pessary, you will have the operation. We lay down the cards and present all the options to our patients and discussing the risk benefits of each. Well, one question is there a cutoff or age cutoff for the operation? Actually, this would really have to be a thorough discussion between the doctor, the patients, and sometimes even the relatives. If the patient is fit, or if the cardiopulmonary clearance is okay, the patient is motivated to have the procedure, and there's no pessary that would fit the patient, despite an advanced age, then we may proceed with surgery. But as I mentioned, we have to be careful. We have to lay down all the cards and tell everything. We also advise that despite the operation, because some people think that once we've done the definitive management, which is surgery, there would be no recurrence. Note that even with the operation, there may still be the chance of pelvic organ prolapse recurrence, and it could be as high as 15% to 30%, even without them doing any strenuous activities, because usually they are already in their 70s or 80s. Genetics. So we can't do away with genetics. If the connective tissues are innately weak, then even without them giving birth at such an age, definitely, they may still have recurrent prolapse. But of course, despite the risks that are non-modifiable, we still advise them to avoid lifting heavy objects, more than 3 kilograms and the likes, and then be a bit more careful and avoid gaining weight. So we still give them proper counseling afterwards. And we do not promise 100% resolution and non-recurrence of pelvic organ prolapse. So the key takeaway message from this discussion, well, I hope that I've imparted some learnings. One is that prolapse is a silent burden. I think we need to be more open. And for doctors or other allied medical professionals, we need to ask your patients for any symptoms. Because definitely they will not volunteer that they have a vaginal bulge or may buwa sila. You have to be a bit more sensitive. And if possible, do pelvic examination and check for prolapse. Note that POP is a condition that should not be stigmatized or ignored as a usual course of aging. And do not dismiss if they tell they have a feeling of something falling out of their vagina. They have to be examined. It is not exclusively to it's not exclusive to the elderly. Not all elderly women would have pelvic organ prolapse, but it's also not unique for some younger patients to have pelvic organ prolapse. So we have to be open-minded about that. It can be managed surgically or conservatively. We have different options. Definitely we can do something about it. And vaginal hysterectomy alone will not address the prolapse. Note that apical support is the cornerstone of many prolapse surgeries. So it goes hand in hand by saying vaginal hysterectomy is not the only procedure that would probably be done in the planning. And even after the surgery, there is the risk of recurrence. And this would have to be thoroughly discussed and counseled with the patient. Thank you so much for your kind attention. I hope you'll have a wonderful afternoon.
Alright, thank you so much, Dr. Cardis. Meron na po akong mga natanggap po ng mga katanungan. Dr. Dion, any comments?
It's very interesting and parang eye-opening, no, na maaring wala tayong kilala na may ganitong problema. Maybe because of that stigma, no? Hindi sila open na i-discuss ito sa atin, sa ating, even sa pamilya. And I think importante for our doctors to ask about these symptoms na enumerate ng doktora. And that's it. And the more important thing here is there's something that we can do about it to improve that quality of life of our women. Maybe not the elderly, but somebody, maybe a younger woman who has these symptoms, may pag-asa na maging mas maigi ang kanilang mga nararamdaman. So maraming salamat, Dr. Cardis.
Thank you.
Thank you, Dr. Rani. Thank you, Dr. Dion. Before we introduce our reactor po, no, I just wanted to mention that I've mentioned that meron na po tayong nakuha mga katanungan, but we encourage everyone to put in the Q&A box here in Zoom your questions. If you could type those in. We also encourage everyone to put in the comment section po in UP and TVUP Facebook pages or in our TVUP YouTube channel where we are being live streamed for today. Okay. Our reactor, she is po the founding president of the Philippine Society for Urogynecology and Reconstructive Pelvic Surgery, also a member of the Board of Trustees of the Asia Pacific Urogynecological Association. Currently, she is the chief of the Division of Urogynecology and Pelvic Reconstructive Surgery po at the PGH Department of OBGYN. Please welcome Dr. Lisa Prodigalidad Habson.
Yes, thank you very much. Congratulations, Ronnie, on a very comprehensive presentation. Pardon my voice. I've lost it somewhere in Europe. But anyways, there are a few points I just wanted to reiterate based on what Dr. Akadis has presented. And I think the first thing that we need to remember is that pelvic organ prolapse is not a life-threatening condition. It is a matter of it's a quality of life issue more than anything else. But nonetheless, it requires intervention, especially if there is already disturbance in visceral function. If there is a problem with the bladder habits, bowel habits, sexual habits, etc. Now, given that, no, one of the main problems we see is that, as Dr. Akadis has mentioned, is that there is usually poor health-seeking behavior, primarily because of a body image distortion, embarrassment, fact that they feel that they don't have time, they have to focus on household responsibilities, but nonetheless, given that, that is the reason why it is particularly important to educate the general public, women in particular, that there is such a thing as as Buwa, as Prolapse, and there is some kind of intervention that can be offered. Now, there is a question earlier about whether this can be prevented. Now, given all the risk factors that were earlier mentioned, you have the predisposing factors, you have the promoting factors, the compensating factors. Ultimately, the question is, can an individual, like any other condition, can this be prevented? Like those who deliver, those who have vaginal births are said to have a greater risk of developing prolapse. Can therefore abdominal delivery or cesarean section prevent it? Studies have shown that the answer is no. Patients who have abdominal deliveries, although they have a diminished risk of developing prolapse, the risk is not zero. So therefore, even in newly gravids, perhaps, actually, my youngest patient, the youngest I've ever treated for a prolapse was a 21-year-old newly gravid. Age, 21 was unusual. The fact she was newly gravid, also unusual. We've had nuns also, single elderlies. In other words, all the factors that come into play, there are certain things that we cannot prevent, we cannot avoid, and we cannot, modify. Now, the short answer for that then is that, can it be prevented? The answer is no. But we can alter the development or the progress of it by earlier on, you can do your pelvic floor exercises so as to strengthen those muscles and tissues down below, so that as you age or as you go through your productive years, you already have an inherent strength, so much so that development of prolapse can be delayed or, ultimately prevented later on, given other factors. Now, there are several options in management. I will not go through all of these, as Dr. Ricardis has mentioned. But the key element here is that, other than educating their patients and giving them the options, is also giving them responsibility and making them participatory in their own care. I say this because by allowing them to participate in the management or being able to choose what form of option they prefer, and educating them regarding the potential problems that will come up with either option, then with respect to compliance in your advice and recommendations, they will be more compliant and therefore there'll be the lesser risk of complications, lesser risk of recurrence, and all of that. Now, as I mentioned earlier, it's not a life-threatening condition. It is a quality of life issue. There are instances wherein, yes, you can observe. There are instances, yes, wherein pelvic floor exercises may be sufficient. There are instances wherein a prolapse may not be sufficient, depending on the severity of the prolapse. And in that, surgery will be necessary. The ultimate aim of any management is the restoration, not just of the anatomy, but of function. And that is what we want to emphasize. In that, for some kasi, they feel that surgery for such a problem is too much. No? But the one thing that must be reiterated is that once there is compromise in visceral function, there is already a need to intervene. And this subsequently would improve their body image, it will improve their well-being, obviously it will improve their bodily functions, and ultimately their quality of life. It is a quality of life issue. It's not cancer, it's not anything else, but I guess what we want to reiterate in the long run is education, and that intervention is necessary in some cases, and that there are interventions that can be given to the patients. Other than that, Dr. Cadiz has presented a very good talk and a very comprehensive talk. So I'll leave my speech at that. And thank you very much.
Okay, thank you so much, Dr. Lisette. There were more additional questions po that we've received. And thank you again to our urogynecologists and pelvic reconstructive surgeons po, no, for just taking the time out for us to be able to understand more about pelvic organ prolapse or Buwa. So we will be consolidating and collating po all of the questions that we have, and then in a few minutes we'll be launching our panel evaluation poll. I will have Dr. Dion start the ball rolling with our very first question po for our Q&A.
Okay, thank you, Dr. Raymond. So I picked out this very interesting question from Joseph Tortona. And as mentioned by Dr. Lisette, we cannot prevent it, but we can probably decrease the chance or delay it from happening. So the question is, can, in terms of prophylaxis or ways, things to do to decrease that chance of developing the prolapse, can exercise help? And then number two is, can the pessary be used as prophylaxis?
I think this was also answered by Dr. Habson a while back. We cannot use pessary as a prophylaxis, but we can encourage our patients to start doing pelvic floor muscle training, even before the onset of pelvic organ prolapse. I mean, there's nothing wrong. It's just an exercise that would have to be done consistently. It would strengthen the pelvic floor muscles, thereby hopefully reducing the chance, but not making it nil. We cannot really prevent pelvic organ prolapse completely, because even genetics plays a factor in that.
Thank you, Renny. Maybe an additional question would be, what kind of exercise, how frequent, how long per exercise would be the recommendation for it to be effective?
There's actually no guideline or strict guidelines about it. There's no protocol. But I've mentioned in the lecture, we have the Kegels exercises. One would need to identify the pelvic floor muscles that would have to be targeted. The usual pictures that one can see when one searches the internet, it's like a yoga pose with the bridge position or the buttocks elevated. It's not actually that. One can do pelvic floor muscle training even while standing, sitting, or lying down on the bed. One would have to squeeze those pelvic floor muscles. No definite time or seconds of holding it, but one can do fast or slow exercises. Sometimes it can be done, let's say, 8 to 10 repetitions, 3 times a day, sometimes even more. As I've said, no definite, no definite protocol. But it would have to be sustained and consistently done for at least 8 weeks, 12 weeks, and sometimes even more. And hopefully that would also bulk up the muscles and improve the tone.
All
Thank you,
right.
Rani. Go
Yes,
ahead,
I
ma'am.
just wanted to add to that. No, a lot of the questions are like, how do you do it? What do you do? What muscles do you contract? That's the basic question that a lot of lay people have in mind. No, now when we're talking about pelvic floor muscle contractions, a lot of women magazines will say they either use Kegels exercises or the pubicoccygis muscle exercises. But the description would be the muscles you contract when trying to stop the flow of your urine. Now, if you imagine your muscle as a bowl, it's the bowl that catches everything in the abdomen. It's a sheet of muscle. And that sheet of muscle or that bowl of muscle is the one that encircles your genital organ, your private parts, including the urinary, the vagina, and the rectum. So much so that when you squeeze to stop the flow of urine, it's also the muscle that you squeeze when you try to hold on to your poop. When you want to go, but you feel you have no time yet, so you try to squeeze your puet, right? You squeeze your buttocks. It's all the same sheet of muscles. So that is one way of teaching women how to contract. Now, the whole action of the contraction is not holding your breath. When you hold your breath, I see you trying to do it. When you hold your breath, you're actually increasing intra-abdominal pressure, which is not correct. You try to squeeze your muscles. You can do it while talking. If you try to imagine if you need to poop and you're holding your poop and you're talking to someone, you can squeeze it without having to stop conversing. So you squeeze the muscles, and the action that should be more or less simulated is parang ganon. You squeeze and hold. Squeeze and hold. It's like a jellyfish. Squeeze and hold. Now, the purpose here is not to make as many contractions as you can, because there's also such a thing as muscle fatigue. So it's squeeze and hold. In order to develop strength, it's trying to hold on to the squeeze. All right. So squeeze and hold, slowly relax. Squeeze and hold and slowly relax. Dr. Akadis was correct in saying that there's no standard regimen with respect to pelvic floor muscle exercises. And studies have shown that if you do it regularly, in a month, you'll get 70% improvement. The emphasis here is trying to get it into a habit like anyone who does any form of exercise, and to do it correctly. Now, in the clinic, you can actually teach them to identify it properly by doing a vaginal exam and asking them to squeeze your fingers. All right. So if you see them squeezing, but they're like this, and then they're doing it wrong. If they're able to squeeze your fingers within the vaginal canal and still be able to converse with you, then they're doing it properly. So what I normally instruct my patients initially is you do 3 sets of 10. 3 sets of 10 meaning 10 contractions, holding it for 10 seconds, and then relaxing for 10, and then again hold, squeeze for 10 seconds and relax, emphasizing that it's not a number of squeezes that you want to achieve. All right. So just like any kind of exercise, it's a gradual contraction and gradual relaxation. Now, if they started that early on, I mean, granted, so many people now are doing a lot of exercises. I personally do not do yoga. I don't do yoga. I don't know how to do yoga. But from my understanding, Pilates and yoga teaches, at least some branches of it, teaches some form of pelvic floor exercises. But the key, the element here that they need to remember is the proper way of squeezing and identifying the proper muscles. Because if you're doing it wrong, then ultimately it's pointless. So just squeeze your puwet, squeeze the muscles, and eventually, that's the proper way. As I'm
Thank you, Ma'am
talking to you, I
Lizette.
can do it now.
I'm imagining everyone in this webinar is probably
Yeah, I saw him trying to
practicing
do
what
it.
you're doing. But we appreciate specifically describing how to effectively do it. And I think we want to echo that, no, it's not the number of squeeze. It's
Yeah.
really how effective you do it for it to be eventually for it to have an effect in terms of decreasing the chance of the prolapse
Yes.
happening. So thank you very much, Ma'am Lizette. Doc Rima, do you have any
welcome.
question on your end?
Okay, we have a special phone-in question that we've been sent po, no. So
Phone in talaga.
yun daw ba pag may nakikita daw po sila, yun daw ba na malapit sa puwet ay considered din daw bang buwa? May kasi tas minsan daw po may lumalabas na dugo. So, yun po.
Almoranas na yun.
Almoral. Yeah, we have to differentiate it from
Hindi ano yan.
hemorrhoids.
Sige po, go ahead.
Rene, you want to answer the question?
Rene.
Well, yes, that should be differentiated po from hemorrhoids. We mentioned the pelvic organ prolapse would have descent in the vagina. So any of the structures that were mentioned a while back. But if it's in the rectal area or sa anal opening, probably it's not pelvic organ prolapse. The patient would need to go to a doctor to ascertain what is that bulge coming out.
Okay. Follow up lang, Dr. Rani, kasi I got this. Meron daw bang, I don't know if it's a family planning question or anything. The question was, meron daw bang parang number of childbirths na parang by this time, medyo mataas na yung chances that you'll have buwa? Yun po.
Theoretically, if a patient has a lot of pregnancies and deliveries, whether abdominal or vaginal, well, you might think that it would increase the risk. But then again, we have to consider that even those without any pregnancy or any vaginal or abdominal delivery can still have pelvic organ prolapse. So to answer that question, there is no designated number of pregnancies or deliveries. We can't really pinpoint a certain number. But in theory, yes, if there's a lot of pelvic floor trauma from vaginal deliveries, it may increase the risk of having pelvic organ prolapse.
Based on studies, all right, one vaginal birth, or let me rephrase that. Every vaginal birth following the first, there will always be an increased risk of 1.5 to 2-fold increase in the risk of prolapse for each subsequent vaginal birth. And that's just a vaginal birth, right? Therefore, yes, there is no limit because a single vaginal birth in itself already puts you at risk.
Okay. Thank you so much. Very helpful. I think, so I don't have any more questions, Dr. Dion. Unless you have one, we can wrap up and go to our evaluation poll po. So for our evaluation poll, we encourage everyone to put in your feedback for each of these 5 questions. 4-point Likert scale. I'll read them as we try to go ahead to our closing segment po. No? Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists use appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we encourage everyone to answer this panel discussion poll as we try to, well, really not sending out po hiwalay na evaluation poll po natin. I'd also like to take this opportunity to greet those who are joining us all the way from the Provincial Health Office of Nueva Ecija in San Jose, Nueva Ecija, from the Department of Health Camarines Sur Treatment and Rehabilitation Center in Camarines Sur, Cebu South Medical Center in Cebu City, Western Visayas Medical Center viewers po natin from Iloilo, all the way to Misamis Occidental Provincial Hospital in Oroquieta City, and the University of Southeastern Philippines in Davao City, Davao del Sur. Internationally, we also have our viewers, our regular attendees po from Chonin Hospital in Taipei City, Taiwan, Lunichi Ali, University of Blida II in Algeria, Canadian Medical Center in Dammam, Saudi Arabia, and University of Hail in Saudi Arabia. So our overseas Filipino workers po in the Middle East, maraming salamat po sa inyong lahat. Okay, so Dr. Dion, what do we have in store for them for next week?
Yes, next week is super special. We will have international speakers from Australia. And we will be talking about caring for the carers, mostly for our nurses. And this is in collaboration with the World Health Organization, Western Pacific Region Office. And because you're hearing that, it also means we will be having Dr. Susie back as our moderator. So please watch out for that. We hope to see you again next week.
Thank you so much. And again, thank you to our urogynecologist po. Maraming salamat to the PGH Department of OBGYN for sharing their insights po for today's webinar. But before we conclude our program, we want to mention that all health updates webinars are archived for viewing at the TVUP YouTube channel. So you go to www.youtube.com/TVUPPH. Meron po doon tab on live and you'll be able to see all 181. After today, 182 na po siya na webinars na nandoon. Including, meron po doon na shorts na tab. So doon din po, in the same YouTube channel, TVUP, you'll be able to see the health updates shorts naman po. These are very, very short consumable videos between 1.5 minutes long, just for you to be able to take in po itong mga nuggets of wisdom na sinishare po natin. So this formally closes our webinar for the week. We look forward again to your company on our next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable death.
So keep safe, keep healthy, and see you online.
Thank you.
Thank you.
Thank you.